Okay, let's dive into something that's, well, a major concern for millions. Did you know that somewhere between 20 to 40% of people living with diabetes will develop kidney disease?
It's a huge number.
Yeah, and if you have type 1 diabetes, that risk is apparently even higher. It really has a significant impact.
It absolutely does.
Yeah.
And it just shows how connected diabetes is to our vital organs,
Yeah.
especially the kidneys.
And that's exactly what we're exploring today. Welcome to the deep dive.
Hmm.
Our mission, like always, is to take a stack of information. This time, it's some focused revision notes, the kind you'd use for medical exams, and really work through them together.
Yeah, pull out the high yield stuff.
Exactly. Pull out the absolute most important knowledge for you. Think of it like us going through your study material, highlighting what you really need to remember, maybe adding a bit of context to make it stick.
Right. So we're using these notes as our guide, our map, through diabetic nephropathy,
Mm.
which is basically kidney disease caused by diabetes. It can seem complex, sure,
Mhm.
but we're going to break down what these notes tell us, step by step.
Yeah, these revision notes, they've already done some filtering, haven't they? But we're going to try and make it conversational, explain why these facts matter, maybe even find a quick way to remember some tricky list or something.
Sounds good.
The goal is you walk away feeling pretty confident about the essentials, all pulled from the source material you're interested in.
Exactly. We'll follow the structure laid out in the notes.
Mm-hmm.
So what it is, why it happens, how it actually damages the kidney physically.
What else it might be confused with.
Right, the differentials. Then who gets it, how it looks clinically, how we test for it,
Mm-hmm.
what we do about it, management, and then the sort of long-term picture prognosis and complications.
Perfect. Okay, let's get started then. Diabetic nephropathy. What's the core definition these notes give us? What fundamentally are we talking about?
Okay, the notes are pretty clear here. It's defined as a progressive kidney disease, and it's caused specifically by diabetes mellitus. The underlying problem, they stress, is that chronic high blood sugar damages the small blood vessels inside the kidney.
Ah, the small vessels. You mean like the tiny filters, the glomeruli? Is that the main damage site?
That's precisely it. Damage to the microvasculature, especially those glomerular filtering units, yeah.
Yeah.
And the consequence of this progressive damage, well, it leads to impaired kidney function,
It's just the path to.
chronic kidney disease, CKD. And unfortunately, it's a leading cause worldwide of end-stage renal disease, ESRD. That's when the kidneys fail completely.
So it's a slow but kind of relentless damage process directly linked to having diabetes. Do the notes mention specific characteristics we should keep in mind too?
Yes. So besides being highly specific to diabetes patients, it's often found alongside other kidney-related issues that are also linked to diabetes. Things like renal atherosclerosis.
Hardening of the kidney arteries?
Yeah. Or increased susceptibility to UPIs, urinary tract infections, and even something called papillary necrosis. They also mentioned that damage within the glomeruli, those filters, can look different under the microscope. It can be either spread out, which they call diffuse, or in specific sort of localized lumps.
And the notes mention a particular type of lump, right? A specific lesion.
They do. If you're looking at kidney tissue in, well, more advanced cases, you might see what are called Kimmel-Steele-Wilson lesions. They're described as nodular glomerulosclerosis, basically, specific protein deposits forming little nodules in the glomeruli. It's a classic finding. Often comes up in exams, that one.
Got it. Okay, so progressive damage to kidney microvessels, especially the glomeruli, leads to CKD, possibly ESRD, often linked to other kidney issues in diabetes, microscopically diffuse or nodular damage, like those Kimmel-Steele-Wilson lesions. Now, what's the most crucial feature the notes highlight? The one thing we absolutely have to look for?
Proteinuria. Protein leaking into the urine. That's the hallmark sign, definitely. The notes describe its typical progression. Starts subtly, maybe as intermittent microalbuminuria.
Tiny amounts of albumin sometimes.
Exactly. Tiny amounts of protein called albumin, found in the urine occasionally. Then, over time, it progresses to constant proteinuria, much larger amounts leaking out consistently. And in some severe cases, this can even blow up into full nephrotic syndrome.
And the notes give us the actual thresholds, don't they? Which is vital for diagnosis and monitoring. How do they define microalbuminuria versus, the more serious proteinuria?
They give specific numbers using the albumin to creatinine ratio, or ACR, usually from a spot urine sample. So microalbuminuria is an ACR of 2.5 milligmol or higher for men, or 3.5 milligmol or higher for women.
Okay.
Or, if you're measuring albumin concentration directly, it's 20 milligmol or more.
And proteinuria.
Proteinuria, the more advanced stage, has much higher thresholds, an ACR of 30 milligmol or higher, or an albumin concentration of 200 milligmol or higher.
Right. So looking at those numbers, ACR 2.5 or 3.5 jumping up to 30, albumin 20 jumping to 200. Proteinuria thresholds are roughly 10 times higher, give or take.
Yeah, it gives you a sense of the scale.
Makes it pretty clear. Okay, so chronic damage, leaking protein is key, starts small, gets bigger. But why does this actually happen? What's the cause? And what puts someone at higher risk?
So at its core, the cause is the prolonged exposure to high blood sugar levels. Chronic diabetes, whether it's type 1 or type 2, it's not just having diabetes, it's the duration and the control of that high glucose over time that damages those small vessels.
So poor control over many years is really the main driver.
Absolutely. The notes also list specific contributing factors and risk factors. Genetic predisposition, that seems to play a role. Some people might just be more susceptible. And importantly, hypertension, high blood pressure. That's listed not just as something that results from kidney damage, but also as a factor that contributes to it in the first place.
Right. Okay, let's just make sure we've got all the risk factors the notes list clearly laid out.
Okay, the big one is definitely prolonged duration of diabetes, especially, like we said, with poor blood sugar control. Worth repeating because it's so central.
Mm-hmm.
Then add hypertension to that, a family history of kidney disease. And the notes specifically mention certain ethnicities having a higher risk. They list African American, Hispanic, and Native American populations.
Okay, so maybe we could group those to help remember, like the times duration of diabetes, the poor controls, sugar and blood pressure, and the inherited factors, family history, ethnicity, time control, inheritance, TCI. Does that help categorize the main risks?
That's quite a neat way to organize them, yeah.
Yeah.
TCI. And recognizing these risks, of course, directly feeds into prevention and management, which we'll get to.
Okay. Speaking of how the damage actually happens, let's get into the nitty-gritty, the pathophysiology. What are the biological mechanisms the notes mention? How does high blood sugar actually wreck the kidney filters?
Right, this is the why behind the damage. The notes outline a few key interconnected processes. So high blood glucose leads to increased production of these things called advanced glycation end products, or AGs.
AG sounds like they prematurely age the kidney or something.
That's actually a really good way to think about it. They're molecules formed when sugar binds abnormally to proteins and fats, and they build up, causing problems.
Right.
This buildup, along with the high glucose itself, triggers inflammatory pathways. It also generates oxidative stress, basically, harmful free radicals doing chemical damage to kidney cells. And importantly, it activates the renin-angiotensin-aldosterone system, the RAS.
Ah, the RAAS system, usually involved in blood pressure.
Yeah, mainly known for controlling blood pressure and fluid balance. But its overactivity here really contributes significantly to kidney scarring and damage.
Okay, so high sugar leads to AGEs, inflammation, oxidative stress, and RAAS activation. What's the end result of all that inside the kidney structure?
The consequences listed are endothelial dysfunction. So the lining of the blood vessels gets damaged, stops working properly.
Okay.
Glomerular hypertrophy, the filter unit's actually enlarged initially, probably trying to cope, but eventually they get stressed.
Right.
Then there's thickening of the glomerular basement membrane. The actual filter material gets thicker, less efficient. That's a key reason for that protein leakage we talked about. And finally, kidney fibrosis, scar tissue formation. And scar tissue means permanent loss of function.
Okay, so those mechanisms lead directly to these physical changes. Messed up blood vessels, enlarged filters, thickened filters, and scarring. It really paints a clear picture of why controlling blood sugar and blood pressure is so vital. You're trying to interrupt the very start of these damaging pathways.
Exactly. Stop the initial trigger that's the best defense.
Now let's think about diagnosis. Say someone comes in, they've got signs of kidney trouble, protein in the urine maybe, or creatinine's off, and they do have diabetes. How do we know for sure it's diabetic nephropathy and not something else entirely? This is where differential diagnosis comes in, right?
Absolutely crucial point from the notes. Just because someone has diabetes and protein in their urine doesn't automatically mean it's diabetic nephropathy. The notes point out that raised albumin or abnormal creatinine could come from other vascular issues, or even certain drugs like diuretics.
So if you see a patient with diabetes who has proteinuria, you can't just, tick the box and move on.
Not at all. There are other kidney diseases, completely unrelated to diabetes, that can cause protein leakage. Things like other types of nephrotic syndrome or perhaps tubulointerstitial nephritis. The notes give us a really valuable list of red flag situations where you should strongly suspect other renal disease, even in someone with diabetes. This list is definitely high yield.
All right, let's hear them. What are those critical signs that should make us pause and think, hang on, maybe this isn't just the diabetes.
Okay, here are the key ones from the notes. First, absence of progressive retinopathy. Diabetic kidney damage and eye damage often track together because they both involve microvascular problems. So if their eyes look fine, but their kidneys are badly affected, that's a major clue to look elsewhere.
Interesting. Okay, what else?
Second, high or resistant blood pressure. If it seems unusually severe or really hard to control, maybe out of proportion to what you'd expect. Third, sudden development of heavy proteinuria. Diabetic nephropathy usually creeps up slowly over years. If loads of protein appears really rapidly, that's suspicious.
Right, not the usual slow burn.
Exactly. Fourth, a quick jump in ACR from normal straight to heavy proteinuria, maybe skipping that microalbuminuria stage or just happening unusually fast. Fifth, significant hematuria, so large amounts of blood in the urine. Some microscopic blood can be seen in diabetic nephropathy, but if it's quite significant, think other causes. And finally, sixth, the presence of systemic ill health. General symptoms like fever, weight loss, joint pain, skin rashes, things that might point to a body-wide systemic disease that's affecting the kidneys as part of its picture.
That's a really practical list. If you see those, you need to broaden your thinking. We need a way to remember that. What about thinking, is it rapid or ODD? Rapid for the sudden onset or rapid ACR shift? OBD for the other things. Ocular sparing, no retinopathy. Disproportionate BP or hematuria, disease, systemic, rapid or ODD.
Rapid or ODD, I like that. Absence of retinopathy, abrupt proteinuria, proportion issues, beef hematuria, illness, systemic, degree of ACR shift.
Yeah, rapid or ODD covers the main points. Look for things that are fast, out of step, or systemic, especially if the eyes aren't involved. It helps flag the atypical presentations.
Mnemonics like that, even if they're a bit rough, can really help jog your memory under pressure. That list of differential points is definitely one to remember.
Absolutely. High yield. Great. So we know what it is, why it happens, the mechanics of damage, and when to doubt the diagnosis. Let's zoom out a bit. Who actually gets this? How common is it? The epidemiology.
The notes state that broadly, somewhere between 20 to 40% of all people with diabetes will develop it, but there's a nuance. Type 1 diabetes carries a higher percentage risk for an individual than type 2.
Ah, okay. So even though there are far more people with type 2 diabetes overall, meaning more total cases of nephropathy will be in type 2.
Right.
An individual person with type 1 is actually more likely, percentage-wise, to develop it.
That's the distinction the notes make, yeah. And the overall rise in diabetic nephropathy cases we're seeing. It's driven by a few things. The increasing number of people with diabetes globally, people with diabetes living longer now because we're better at managing heart problems.
Which gives kidney complications more time to develop.
Exactly. And also, type 2 diabetes is being diagnosed earlier in life these days.
So it's a growing problem tied to the diabetes epidemic itself and also better survival from other issues.
Mm-hmm. For type 1 specifically, the notes mention it's the main cause of chronic kidney disease in working-age adults. And around 40% of those with type 1 will show microalbuminuria after having the disease for 30 years.
40% after 30 years, wow.
For type 2, the incidence is also rising, and they say about 20–25% show microalbuminuria after just 10 years. So, maybe showing up a bit sooner on average in type 1 relative to duration, but it's a huge problem for both types, especially the longer someone has diabetes.
Okay, so common, a major driver of CKD, prevalence linked to duration and type. How does someone with this actually feel?
Yeah.
What are the clinical features, the symptoms?
This is a really, really important point from the notes, and it underlines why screening is so crucial. In the early stages, it is often asymptomatic.
Right, you don't feel anything's wrong until the damage is already quite significant?
Exactly that. By the time symptoms appear, kidney function is usually already noticeably impaired. The notes list the symptoms that develop as it progresses. Persistent proteinuria that's detected by tests, you don't usually feel it. Sometimes hematuria, blood in urine, which you might see if it's severe. Increased blood pressure. Edema, so swelling, often starts in the legs. Fatigue. Decreased appetite, maybe some weight loss.
Those later symptoms sound like pretty general signs of the kidneys just not filtering waste properly anymore.
They are. The notes reiterate that diagnosis is typically made via screening tests, long before these noticeable symptoms develop. They also mention again that diabetic retinopathy may precede nephropathy, reinforcing that eye-kidney connection we saw in the differential section. It's often a clue telling the same underlying story.
And those risk factors we talked about, they pop up again here too, don't they? Like poor glycemic control, smoking, dyslipidemia, hypertension. Seems like they're not just causes, but things we look for clinically because they're all tangled up together.
Precisely. Their presence just reinforces the likelihood of diabetic complications, including nephropathy. And another critical point the notes make, diabetic nephropathy significantly increases a person's risk of cardiovascular disease. It's not just a kidney problem, it's a major red flag for heart attacks and strokes down the line.
That cardiorenal link is so important. And the advanced symptoms listed peripheral edema, getting breathless on exertion, fatigue just highlights that by the time you're feeling those, the disease is really quite progressed.
So the take-home is, early stages are silent. Screening is absolutely paramount.
Which leads us nicely into how we find it, the investigations. What tests do the notes say we should be using?
Okay, the notes outline the standard workup. First, urine tests. You're looking for protein, obviously, and indicators of kidney function. A standard urine dipstick can pick up larger amounts of protein, but for that crucial early microalbuminuria stage, you really need the more sensitive tests, like the spot urine ACR we mentioned with the definitions.
So urine protein tests, specifically ACR, right at the front line.
Definitely. Next up, blood tests. Measuring serum creatinine is essential because we use that to calculate the estimated glomerular filtration rate, or eGFR. The notes are clear. eGFR declines as kidney disease progresses, so monitoring it is key to tracking function over time.
Urine and blood tests are the mainstays then. Anything else?
Imaging studies. Typically an ultrasound of the kidneys. This is mainly used to look at the size and structure of the kidneys, and importantly, to rule out other potential causes of kidney problems like blockages or cysts. In early diabetic nephropathy, the kidneys might look normal, or even a bit enlarged. They tend to get smaller only in very advanced stages due to scarring.
Okay. And finally, a kidney biopsy. Is that common?
The notes mention it's done in some cases. So not routine for every diabetic patient with protein in their urine. It's usually reserved for situations where there's diagnostic uncertainty, maybe if those suspect other renal disease, if criteria we discussed are ringing bells and you really need a definitive answer. Or sometimes to assess the severity of damage if it might significantly change the management plan. It's the most direct way to actually see the specific microscopic changes.
So the core investigations are urine, ACR, maybe dipstick, blood, creatinine, eGFR, and imaging, ultrasound. Biopsy is more for the complex or unclear cases. We could call that the UBI strategy, urine, blood, imaging. Plus biopsy when you're, well, unsure or need specifics.
That's a helpful way to frame the toolkit, yeah. UBI plus B for tricky ones.
Okay, great. We've covered the what, why, how, who, how it looks, and how we find it. Now let's move to the really critical part. What do the notes tell us about managing diabetic nephropathy, particularly in the UK context they seem to reference?
Right, management. The notes strongly emphasize aggressive control of several key factors. Think of these as the pillars. First, blood sugar control. The target HbA1c mentioned is below 7%. It is around 48, 59 millimole in fork. That's achieved through lifestyle and medication.
Pillar 1, sugar.
Pillar 2, blood pressure management. This needs to be aggressive. Target below 130, 80 millimole of Hg. And the key medications here are ACE inhibitors, ACEI, or angiotensin receptor blockers, ARBs. These are vital not just for the BP number, but because they directly block that RAAS system, one of those damaging pathways we talked about earlier. So they're kidney protective.
Pillar 2, BP, using ACEs or ARBs.
Pillar 3, lipid management, using statins to control cholesterol levels. Absolutely crucial because of that strong link between diabetic nephropathy and increased cardiovascular risk.
Okay, pillar 3, lipids. So relentless focus on hitting targets for sugar, BP, and lipids.
Absolutely. And lifestyle changes are foundational too. Quitting smoking is non-negotiable. Improved nutrition, weight loss if needed. Dietary modifications usually include reducing salt intake. Now, the notes also mention low protein diet, but there's a slight oddity here.
Oh, what's that?
Well, under general management, it says implement a low salt and low protein diet. Consider high protein diets for type 1 diabetes with nephropathy, which sounds strange. But then later, under the specific points for managing microalbuminuria proteinuria, it clearly says advise against high-protein diets for type 1 diabetes with nephropathy.
Ah, okay, a direct contradiction within the source material. That's tricky for someone using these notes. How do we handle that?
Yeah, it's a good catch. When notes seem to conflict like that, you usually look for the stronger statement or what lines better with standard practice. Given that general nephrology advice is usually against high-protein diets and kidney disease to reduce the load on the kidneys,
right,
and that later note specifically advises against it. For type 1 with nephropathy, it's much more likely the intended advice is to avoid high-protein diets, especially in type 1 patients with this condition. The first mention might be a typo or poorly phrased.
Okay, so we'll go with the clearer, more standard advice. Low salt, generally low protein, and specifically advise against high protein in type 1 with nephropathy, while acknowledging the source had that confusing bit.
Exactly. That
Mm.
seems the safest interpretation. Yeah. What about newer medications?
Yes. What do the notes say there?
They do mention medications like SGLT2 inhibitors, specifically dapagliflozin is named, for type 2 diabetes with CKD. They even give specific ACR thresholds for considering these. Generally over 30 millimole for SGLT2s, maybe 22.6 millimole, or more specifically for dapagliflozin, according to these notes. These drugs have shown really significant benefits for both the heart and kidneys in this group.
So SGLT2 inhibitors are definitely part of the modern toolkit for type 2 patients with kidney involvement showing proteinuria.
Yeah. Finally, management involves regular monitoring and knowing when to refer. You need to keep checking urine albumin and serum creatinine for the eGFR regularly, see if things are stable or getting worse. And referral to a kidney specialist, a nephrologist, is recommended when the eGFR drops below a certain level. The notes specify below 30 milliminin, 1.73 milliminutes.
Okay, so manage aggressively. Sugar, BP, lipids. Use protective meds like ACEI, AirBs, maybe SGLT2s for type 2. Mind the diet. Low salt, low protein. Avoid high protein in type 1. Monitor closely. And refer to nephrology when eGFR hits 30. The notes also loop back to primary prevention, right?
Yes, they reiterate that the absolute best way to prevent or slow this down is optimal control of glucose, BP, and lipids right from the start, along with lifestyle. Good glucose control is specifically highlighted again as helping to reduce microalbuminuria and stop it progressing.
So stopping microalbuminuria developing or getting worse is a key part of preventing the later, more serious stages.
Exactly. And managing microalbuminuria and proteinuria specifically involves hammering those key strategies again. Good glucose control, HbA1c below that 48-59 range, manage all cardiovascular risks aggressively, definitely use ACE inhibitors in all adults with confirmed nephropathy and type 1 diabetes. That's a specific call out for type 1.
Right.
Consider SGLT2 S-DAPA for type 2 plus CKD. Hit that BP target below 40-80. And again, avoid high-protein diets in type 1 with nephropathy. It sort of pulls all the management pieces together for that specific stage.
Excellent summary. Now, looking ahead, what's the prognosis, the likely outcome, and what are the potential complications the notes mention?
The prognosis, well, it's really tied to how early it's caught, how well it's managed, and what other health problems a person has. The notes do offer some hope, though. Early detection and aggressive control of blood sugar, blood pressure, and lifestyle factors can significantly improve the outlook.
So catch it early, hit it hard, and you can definitely change the trajectory.
Yes. But despite best efforts, it can still progress to end-stage renal disease,
Mm.
ESRD, requiring dialysis or a kidney transplant. The notes give some specific figures on prognosis. For type 1 diabetes with microalbuminuria, they say about 19-24% will go on to develop overt proteinuria. Aggressive BP therapy is particularly emphasized as crucial for prognosis in type 1. And for both type 1 and type 2, the presence of proteinuria and uncontrolled hypertension are strongly linked to increased mortality.
So protein in the urine and high blood pressure aren't just signs of kidney damage, they're actually markers for a higher risk of death overall.
Crucially, yes. And for type 2 diabetes, the notes reiterate that very high cardiovascular morbidity and mortality risk for those with microalbuminuria or overt nephropathy. That connection between kidney damage and heart disease is just a constant central theme because often cardiovascular events are what cause the most problems first. They mention about 20% of type 2 patients with microalbuminuria develop proteinuria after 10 years. Similar timescale to the type 1 stat, but starting from a different baseline population.
Right. And the list of complications mentioned makes that clear, alongside other systemic effects.
It does. The major one is ESRD, leading to dialysis or transplant need. Cardiovascular disease is prominent, directly linked to the hypertension and widespread atherosclerosis that often go hand in hand. Then, because the kidneys aren't doing their job properly, you get systemic issues like anemia.
Low blood count.
Yeah. Electrolyte imbalances like potassium or phosphate levels getting dangerously high or low, and bone disease, which is secondary to the mineral imbalances. And finally, impaired kidney function can weaken the immune system, leading to increased susceptibility to infections.
Wow, it really does have a domino effect on the whole body when the kidneys start to fail. Anemia, fragile bones, getting sick more easily.
And the notes briefly state that preventing and managing these complications involves, you guessed it, ongoing monitoring and specific interventions, bringing us right back to our management strategies.
Okay, let's quickly test ourselves with a scenario just to pull a few of these points together. Imagine you're reviewing a patient, type 2 diabetes, had about 8 years. Their HbA1c is actually pretty well controlled, say around 6.8%. Their blood pressure is managed with an ACE inhibitor, usually sits around 125/75. BT, in the last 6 months, they've suddenly developed significant proteinuria, and their eGFR has dropped quite sharply, maybe from normal down to around 45. You check their eyes, absolutely no sign of any diabetic retinopathy. Based on those red flags we discussed from these notes, what should you be thinking right now?
Okay, well, based on those suspect other renal disease if criteria, you should definitely be thinking that this presentation is atypical for standard uncomplicated diabetic nephropathy. The sudden development of significant proteinuria combined with the complete absence of retinopathy despite 8 years of diabetes, those are major red flags from the notes. Diabetic nephropathy is usually slow, progressive, and often mirrors the eye changes. So while their diabetes is clearly relevant, that sudden change and the lack of eye involvement mean you absolutely must investigate other potential non-diabetic causes for their kidney problems. You can't just assume it's the diabetes here.
That scenario perfectly highlights why those differential diagnosis points are so important. It's not just about knowing what diabetic nephropathy is, but also knowing what it isn't and when to broaden your investigation.
Precisely. Understanding the typical picture progressive, silent early on, caused by chronic high blood sugar damaging microvessels marked by proteinuria, diagnosed by screening, managed aggressively with glucose, BP, especially ACE-IRBs, lipid control, maybe SGLT2s for type 2 is vital. Knowing it's a major driver of ESRD and ramps up cardiovascular risk, but always keep those red flags for other diagnoses, those rapid or ODD features in the back of your mind.
That was a really thorough exploration guided by these specific notes. We've touched on everything from the microscopic damage right through to population impact and the critical management strategies.
Yeah, hopefully breaking it down like this, following the structure of the notes, helps clarify the key points and makes the information feel a bit more organized and actionable for you listening.
That's definitely the aim. And thinking about the sheer scale of diabetes globally and just how many people are potentially at risk of this specific complication, here's a thought maybe to leave you with.
Okay.
Well, all the advanced management, the specialist referrals when eGFR drops low, that's all crucial. Doesn't the whole picture we've just painted, especially that long silent phase, the huge importance of early control, doesn't it really argue for the absolutely fundamental role of primary care?
Go on.
I mean, diagnosing diabetes early, relentlessly pushing for optimal blood sugar, blood pressure, and lifestyle management right from day one in that primary care setting, maybe that's the single most impactful strategy we have on a population level. Preventing or slowing this devastating complication long before a kidney specialist even needs to get involved. What do you think?
That's a powerful reminder, isn't it? That prevention and really proactive early management in primary care is often the most potent medicine we have for chronic conditions like this. It sets the stage for everything that follows.
Indeed. So if you are using notes like these for revision or just want to explore this or other medical topics further, you might find the resources that inform this deep dive helpful. We've been working through revision notes today, and if you're looking for materials specifically related to medical exams like the MSRA, you might want to check out passthemsra.com.
Right, passthemsra.com.
And also freemsra.com.
Freemsra.com both offer useful resources to support study in that area.
Absolutely. Well, thank you for joining us for this deep dive into diabetic nephropathy.
Thank you. It was a good discussion.